of Indian Psychiatric Society, Tamil Nadu Chapter, Research Capacity and Building Committee. We welcome you all for this RCBC program, second RCBC program of this period. We would like to welcome our speaker, Dr. Rajshekhar Bipeta sir, as well as the student who is joining with us. And we welcome all the Tamil Nadu IPS EC members, as well as we welcome all the professors, consultants from all the states who have joined with us here. Just we talk to Dr. G. Prasad sir, who is with us today. And I welcome all the postgraduates who has joined for this program. Now, I would like to hand over this program to Dr. S.R. Nirmal sir for welcoming the speakers. Sir, over to you, sir.
Thank you, Sharam, sir, for the opportunity to introduce the speakers here. I take a lot of pride to introduce Dr. Rajshekhar sir, because I knew him from my alma mater. So, sir was senior to me in CMC. And other than that, he was our mentor in our PCPR Psychiatry research course. So, welcome, Dr. Rajshekhar sir. And sir has finished his DPM from Nadu, and then he did his DNB from Hyderabad, Osmania. And he's also interested in both research and education, medical education. He's done an acne course. That he's done a lot of research. He's almost published around close to 50 papers and presented nearly 50 conferences. And he has been the principal investigator of both governmental ministry related projects and also other genetic projects. And he is part of this ICMR funding PRIA agency, which is for psychiatric research related funding. It is guided in a co-guide for many these theses. And that sir is currently, we all know, is the editor of the IJPM, and has been putting these editorial posts in both the state journals and Osmania. And the research, I think I wouldn't go into details into it, although it was older paper. There's a lot of information which we can get from this paper. We expect to listen to the PG who's going to present it. And our postgraduate is from Mahatma Gandhi Singh. So we are all eager to hear how he's presenting, and probably have sir has recently published, Rajshekhar sir has recently published a synthesis on rating scales in psychiatry. So probably that is one area where sir is very interested in psychometry and assessment of it, and eager to both listen to his article and his presentation.
A very good afternoon to all esteemed guests present. I'll be presenting a research article as part of this journal club today. I am extremely thankful to my moderators, Dr. Shivanand Katimani and Dr. Anbalagan. I am Dr. Prabjot Dhillon, first year PG resident from Department of Psychiatry, Mahatma Gandhi Medical College. The article in question was published in the Child and Adolescent Psychiatry and Mental Health Journal. The journal is the official publication of International Association for Child and Adolescent Psychiatry and Allied Professions. It is a peer-reviewed. The journal has an impact factor of 3.4. The research article was published on the 20th of June, 2013. The article is titled as A Cross-Sectional Study of Insight and Family Accommodation in Pediatric Obsessive Compulsive Disorder. It is authored by Dr. Rajshekhar Bipeta. This is the well-structured and formulated abstract of the article. We will start with the background. It sheds light on obsessive compulsive disorder, which is the chronic anxiety disorder characterized by obsessions, that is, unwanted and recurrent thoughts, ideas, feelings, or mental images, which drives the patient to engage in compulsions, that is, behaviors or mental acts designed to prevent or reduce anxiety. We find pediatric OCD present in about 1 to 4% of the population, and it becomes even more important as majority of the adult cases of OCD, up to 80%, have an onset during childhood. The present recommended treatment regimes involve cognitive behavioral therapy for the mild to moderate cases of OCD, and we can add selective serotonin reuptake inhibitors to CBT for the severe cases. We see remission rates of 39% with cognitive behavioral therapy alone, and for the combination therapy of cognitive behavioral therapy and SSRIs, we see remission rates of 54 to 69%. The study also tells us that the significant predictors of treatment outcome of OCD in children, which have been recognized earlier, are OCD severity, functional impairment, insight, that is the recognition of obsessions and compulsions of OCD as unreasonable or excessive, comorbid externalizing symptoms, and family accommodation, that is the actions taken by the family members in facilitating the child's rituals, which can be in the way of avoidance of triggers. The previous studies that are referred to by the authors involve Storch et al. The findings of Storch et al. Report that patients with low insight have increased levels of OCD severity and functional impairment along with family accommodation. Lewin et al. Reports that insight is correlated positively with age, but it does not find an association between insight and OCD symptom severity, OCD age of onset and illness, and family history of OCD. Perez et al., on the other hand, reports that family accommodation was not associated with OCD severity, externalizing and internalizing behavior. Caporino et al. Informs us that family accommodation mediated the relationship between OCD symptom severity and parent-reported functional impairment. The need for the study is the result of the two main studies being incongruent to each other, and there being not a lot of literature present on poor insight in adults or children. The study is aimed at studying the clinical correlates of insight and family accommodation. It aims at building on the limited existing data from other studies. And in order to understand the focus of intervention among family members and youths with OCD, they studied the correlations between the study variables and the two family accommodation subscales. On the basis of earlier research, it was hypothesized that insight is associated with age, duration of illness, symptom severity, OCD severity, functional impairment, and family accommodation. Family accommodation was associated with disease and symptom severity, functional impairment, and the presence of comorbidities. It was also hypothesized that family accommodation mediates the relationship between OCD symptom severity and functional impairment because it reinforces the child's irrational behavior of avoiding triggers and getting involved in compulsions, which eventually leads to the maintenance of functional impairment and is counterproductive to cognitive behavioral therapy. The study was conducted on outpatient basis in a psychiatric clinic in Hyderabad, Andhra Pradesh, India. It's a cross-sectional study. The sampling that was used was consecutive and convenience sampling. Assent from the subjects was obtained, informed consent from the parents was obtained, screening was conducted, demographic details were collected. After that, diagnosis was formulated using the KIDI-SATS present and lifetime version, which is based on the DSM-4 psychopathology criteria. And severity of OCD was measured using Children's Yale-Brown Obsessive Compulsive Scale. Family accommodation scale, the parent report version and the child report version was used for family accommodation. Child obsessive compulsive impact scale, revised child version, and child obsessive compulsive impact scale, revised parent version was used to measure the functional impairment. Insight was assessed using a semi-structured interview by the clinician, and the scale was created by Lewin et al. And insight was rated on a 5-point scale, ranging from excellent to delusional. The group assignment was done on the basis of insight. The low insight group consisted of children with mild to severe impairment in insight, and the high insight group had children with excellent or good insight, that is without impairment in insight. The inclusion criteria involved all treatment-seeking subjects below 18 years of age that were diagnosed with OCD as per the DSM-4 criteria. Subjects with completed or interrupted studies were also included, they were not excluded. Parents willing to comply with the study procedures were included. The exclusion criteria involved subjects that had history of substance use in the last 1 year, subjects that had organic disorders, had cognitive impairment, or had below average intelligence, or had other axis 1 disorders. Subjects with high suicidal tendency were also excluded. Parents with below average intelligence, OCD, obsessive compulsive personality disorder, or any other major psychiatric disorder were excluded. If one parent suffered with any of these disorders, the other parent was used to comply with the study procedures. The statistical analysis was done using the SPSS version 20. Insight was evaluated as a categorical variable. Analysis of variance ANOVA was used to examine the variables in the low and high insight groups. Associations between the remaining variables were analyzed by Pearson's correlation. Mediation analysis was carried out using the Barron and Kenny causal steps approach. And in addition, a bootstrap confidence interval for the indirect effect was obtained. The final study sample comprised of 35 youths. 42 subjects were contacted, but parents of 4 subjects refused to participate. 1 subject was on psychotropic medication, 1 subject was highly suicidal, and both parents of 1 subject had active symptoms of schizophrenia, so they were excluded. The mean age of the subjects was 13 years. The mean age at was 8 years.
എന്തായിരുന്നു സംഭവിച്ചതെന്ന് വെച്ചിട്ടുണ്ടെങ്കിൽ അത് ഞാൻ കുറച്ച് ബ്രീഫായിട്ട് പറയാം. ഫസ്റ്റ് ഇയർലി
The mean severity of the disorder was calculated at 4.49. The results show for comorbidity that at least one comorbidity was present in 14 subjects. That is 40% of the subjects had a comorbidity. 17.4% of the subjects had multiple comorbid disorders. Depression was the most common co-occurring disorder, and the other comorbidities that were present were ADHD and conduct disorder. Family history of OCD was present in 3 subjects, and all 3 subjects were part of the high insight group. But because the sample was too small, subgroup analysis was not carried out. Insight. Of the 35 children, 28 subjects had high insight, while 7 subjects had low insight. And we will see that in the pre-adolescent age group of 7 to 10 years, 44%, only 44% have high insight, whereas in the 11 to 13-year age group, we see 62.5% with high insight. And in the 14 to 17-year-old age group of old adolescents, we see 72.2% of subjects having high insight. Subjects with low insight into their symptoms were younger, had more severe OCD, had more severe symptoms, and they were accommodated to a greater extent by the family members. We did not find a difference in duration of illness and functional impairment, both on the child and parent reported scales. For comorbidities, depression was significantly more frequent in youth with low insight than youth with high insight. And ADHD and conduct disorder, when they were present only in the low insight. For family accommodation, no statistically significant differences in family accommodation were found in OCD patients with or without comorbidity. But we see family accommodation was significantly related to disease severity, symptom severity, parent-reported functional impairment, and child-reported functional impairment. Both family accommodation functional impairment scales were significantly related to disease severity, symptom severity, parent and child-reported functional impairment. The parents that took the functional family accommodation parent report scale showed that 54.29% parents provided reassurance, 45.7% parents participated in the compulsions of the subjects, and 34% parents facilitated avoidance for the subjects. Mediation analysis. Mediation is demonstrated when the independent variable, that is severity, significantly correlates with the dependent variable, that is functional impairment. The independent variable is significantly related to the mediator variable, that is family accommodation. The mediator variable has a unique effect on the dependent variable when the independent variable is controlled. The effect of the independent variable on the dependent variable diminishes significantly when the mediator is added. And we find that the total effect of severity on functional impairment was significant. For each 1 score increase, we see an increase of about 17.7% increase in the functional impairment. For severity was significantly predictive of the hypothesized mediating variable of family accommodation. When controlling for severity, family accommodation was significantly predictive of functional impairment. Thus, the indirect effect of severity on functional impairment through family accommodation was statistically significant. However, the direct path from severity to functional impairment was not statistically significant. Therefore, the effects of severity on of functional impairment were totally mediated by the family accommodation. Discussion. So the focus of the study was to understand the clinical correlates of insight and family accommodation in a representative sample of the pediatric OCD population. And the study finds significant associations between insight and age, insight and comorbid depression. In agreement with earlier findings, low insight in subjects was found to be significantly associated with disease severity, symptom severity, and family accommodation. A significant finding of the study is the relationship between insight and age. The study reports the diagnostic differences in insight with respect to age between adults and youth with OCD. And this is very crucial because if the diagnostic criteria of adults is applied to children, OCD diagnosis will be missed in a number of patients with poor insight. Parents of youth with low insight endorsed higher levels of family accommodation than did parents of patients with high insight. Family accommodation was positively related to child functional impairment. Family accommodation and the two subscales were significantly related to both symptom severity and parent-reported functional impairment. As hypothesized, family accommodation mediated the relation between OCD symptom severity and parent-rated child functional impairment. The findings are different from those of Lewin et al. Lewin et al. Found no significant differences in OCD severity in low and high insight group, but it is the opposite for us. And Storch et al. Found no significant differences between both parent-reported and child-reported functional impairment in the two groups. The strength of the study is that there is no published original research study which has used a 12-item version of the family accommodation scale, because this scale has a role in etiology, maintenance, and the treatment of pediatric OCD. The study also examines for differences in family accommodation based on comorbidity, which was not done in previous published studies. The limitations, as mentioned by the authors, are that the study is a clinic-based study and it has a cross-sectional design, which limits the generalizability of the findings to broader populations, such as community samples. The investigators were not blinded to the study procedure. Younger children could have been rated with lower insight due to interviewer bias. Children were not matched for age in the low and high insight groups. Some instruments are not standardized for the Indian population. Scope for research in the future: the assessment of the relationship of insight with specific obsessions and compulsions, the assessment of the development of insight as the child grows, insight assessment instruments specific to this pediatric age group, and the influence of biopsychosocial interventions on insight need to be studied. In conclusion, the authors tell us that younger children may have poor insight, and the requirement of an intact insight may cause OCD diagnosis to be missed. Pediatric OCD with low insight may be a distinct subtype of the disease because it has increased disease and symptom severity. Families of pediatric patients with more severe disease and symptoms accommodate the disorder to a greater degree. And family accommodation is a mediator of functional impairment and a significant predictor of treatment outcome. Thus, involving the family in the child's OCD treatment may provide better outcomes to treatment. Thank you.
Okay, thank you, Dr. Prajot Dilan. Minutes, go ahead. Your critical appraisal of the article.
Yes, sir. So for the title and abstract, we did not find any critique. The study design was mentioned in the title. The abstract was structured and informative. Same for the background. The study addresses a very crucial area of research in pediatric OCD. And both factors, insight and accommodation, are modifiable. So it is extremely important that clinicians and parents understand. The objectives and hypotheses that were formulated were, again, there was clear rationale offered for it, and they were from very respectable studies. For the methodology, we have the location, we have the measures of data collection, and the use of structural equation modeling for mediation analysis is a strength. Like, it allows for us to understand the relationship between the independent and the dependent variables. The limitations, as per my little understanding of research knowledge, sir, is that the period of recruitment could have been specified. I have, through this conversation, understood that a large sample size is very tough to come across, but a larger sample size representative of the target population would make the findings more robust. Convenient sampling may have limited the study's ability to generalize results beyond the specific clinic setting, and the subjective rating of severity and insight can affect consistency and accuracy. The reliance on self-reported data from parents may introduce response bias, as parents may downplay or exaggerate the extent of accommodation. For the results, I think they were extremely clear. The associations between insight and family accommodation were mentioned. The limitations were almost like specified. The only limitation I found, now I'm not very sure about this, but the values of the tables do not correspond to the stated results. The table that was brought in question, the second table. So the results tell us that the low insight group has higher severity of symptoms, but the table does not correspond to these findings. And for the discussion, the strength is obviously a cautious interpretation of results. We are told that the low insight could be due to neurodevelopmental factors. We are like everything else is specified clearly, but the only limitation is that the potential bias, that the response bias could have been addressed. Thank you, sir.
Thank you, Prajot Dilan, and you have given a dare to give your own critical appraisal, and it is your opinion. We will end it here. We will now, we had a wonderful discussion with Professor Bipeta. He's answered keenly everything. Discussion has enriched us. Over to Professor Bipeta, sir.
Yeah, thank you, Dr. Shivanand. Just a suggestion, Dr. Prabjot, you could have actually taken the stroke guidelines as a, you could have that for your critical appraisal, you could have used a stroke guideline for an appraisal. And definitely the one which you have pointed out, I look into that table 2. You said there is some discrepancy in the numbers, but now because it's an old study, I think I cannot even put a message to the journal to rectify it. Thank you very much for the appraisal.
No, sir. Thank you, sir. It was an honor to praise the article. Thank you.
Sir, stage is yours, sir. Professor Bipeta.
Should I go ahead with presentation now?
Yes, sir. Yes, sir. Yes, sir.
Okay. Good afternoon, everyone. Respected chairperson and moderators, respected Shivraman sir, Nirmal sir, Dr. Shivanand, Gopalan sir, and all my seniors, my friends and my colleagues, and Prasad Rao sir, for being here for this. For a person like me, you have attended this session, so thank you so much. And to all the IPS Tamil Nadu branch for honoring me to be here. It's a privilege to be here and to get appraised by postgraduates. I really appreciate that. Now I'm going to talk about this topic, internet addiction disorder. So I just wanted to keep it open, like I just said internet addiction in the flyer, because I wanted to make it little thing, like I want to talk about controversies. My idea here is not to talk about the whole internet addiction and the internet addiction disorder, but the controversies which surround that concept. I'm not going to really look into each and every article, but the articles which have come to my attention, and that is what I'm going to talk about. Few articles I'm going to talk about. So we all of us know about this person called Young, who is a psychologist who proposed this Young's diagnostic questionnaire, based on which she developed the concept of internet addiction and internet addiction diagnostic criteria. This was basically based on the very famous pathological gambling concept. See, one thing is pathological gambling is now undoubted a psychiatric disorder. There is now very good evidence to say that pathological gambling is actually a psychiatric disorder. It needs treatment and all that. But taking that as a base, this particular YDQ was developed. So all of you know, but I'll just briefly read about it. The first criteria is, do you feel preoccupied with the internet? Do you feel the need to use the internet with increasing amounts of time? Have you ever repeatedly made unsuccessful efforts to control, cut back, or stop internet use? Do you feel restless, moody, depressed, or irritable when attempting to cut down? Do you stay longer Do you stay online longer than originally interested? Have you jeopardized? Means, is there any impairment because of this internet seeking behavior? Have you ever lied to the family members? Do you use the internet as a way of escaping from problems or to relieve a dysphoric mood and all that? Okay, now these are the basic YDQ criteria based on which lot of papers have come up. Now, there's a very big criticism of Young's diagnostic questionnaire. The initial one was as early as 2001. I really like this person because he was one of the first persons to actually talk about this criticism surrounding IA criteria. This particular group says that the first criteria could account for numerous behaviors that we would not necessarily classify as an addiction. For example, I'll just give you that this is a argument this particular group has talked about. If you see the first criterion, the Beard and Wolf 2001, they have taken the example of a new mother. Okay, so the first criterion is, do you feel preoccupied with internet? So this group says, suppose take an example of a new mother who has delivered a baby and is preoccupied with thoughts of her new baby. The second criteria, do you feel the need to use internet with increasing amount of time? So here the new mother also desires to have increased amount of time with her child. Third criteria, have you repeatedly made unsuccessful efforts to control, cut back or stop internet use? The newborn mother, this mother also will make, has been unsuccessfully able to control, cut back or stop her interaction with child. Fourth criteria, do you feel restless, moody, depressed or irritable when you are trying to cut down internet use? Mother also feels restless, moody, depressed or irritable when she is away from the child. Do you stay online longer than originally intended? A new mother also interacts with child for longer time than originally intended. Now this particular group says, now based on these 5 criteria, which is actually akin to the Young's 5 diagnostic criteria, are you going to say that mother is addicted to child? So this is one of the best criticism I have found to date. And there's another one which I will talk about later. Now, this group actually has said that there's a need for improving on the Young's diagnostic criteria. They say that at least the first 5 criteria of those criteria should be fulfilled. Plus, they say that at least one of the following 3 criteria should be fulfilled to say that the person is addicted to net. First is jeopardized or risk the loss of significant relationship, has lied to family members and uses the internet as a way of escaping. So what they are saying is, it is not just because a person is fulfilling the criteria for YDQ, he is actually internet addicted, but at least one of the following 3 criteria should definitely be fulfilled to say that the child is or the person is internet addicted. Now, unfortunately, what has happened is, despite after this IAT or YDQ, that is Young's Diagnostic Questionnaire and Internet Addiction Test by Young's, so many scales were developed throughout the world. But even to date, as recent as 2024, people continue to use Young's Diagnostic Questionnaire and Internet Addiction Test. So I did just a recent PubMed search with the criteria. The search words for internet addiction disorder, Young's Internet Addiction Test. I made a filter for 5 years, and I was surprised to find that even now in 2024, there are 253 results using IAT. Now, the most recent systematic review was published in India. Actually, now what I have done is I have stopped, we at Indian Journal of Psychological Medicine has stopped taking papers which are actually talking about internet addiction and related issues. The only reason we considered this paper, which is not yet online, which is online now, it is there online, which was published recently from NIMHANS. This was actually a systematic review and meta-analysis, and it was about internet addiction, where using all those studies where IAT was used as a scale. So results were that the prevalence of mild, moderate, severe, and any level of internet addiction is around 37%, and 18%, 0.8%, and 58%. And various psychosocial factors such as male, being single parent, comorbidity, depression, stress, anxiety, interpersonal issues, and loneliness were found to be associated with internet addiction. So this is the latest systematic review which is published in our journal. So what I'm trying to say here is, despite so much evidence that YDQ is not the answer for assessment of internet addiction. It continues to be the gold standard, unfortunately, despite so much of criticism. Now, I'll talk about, this is something which was published. This is again an old article published in 2011. This was an original article which was published in PLOS ONE. Please remember, this is a very prestigious journal. So there is a saying in Telugu, Dimma Tirigi mind block ayindi. Basically what it means is, I was really shocked to read this paper. So I just briefly want to talk about this paper. I just want to tell the crap which is there in relation to internet addiction all over the world. So this particular paper, psychologist was one of the authors. So what did they want to do in this study? They wanted to evaluate the role of pathological disorders in IAD. They wanted to identify pathological problems in IAD. They wanted to explore the mental status of internet addicts prior to addiction, including the pathological traits that may trigger IAD. So the background was very good. What they did, if you look into the methodology, what they basically did is, they have recruited 2132 students who entered the university in September 2008, and they administered SCL 90. So symptom checklist 90 is one of the instruments which is used to assess psychopathology. They were again seen in September 2009 after 1 year. The same 2132, mind you, were assessed on Young's online IAT, online. This is a very important word. What they found, out of these 2132 students, in 2009, 66 students developed IA, internet addiction. So they wanted to know if these 66 students had internet addiction when they entered university, that is in September 2008. They made a retrospective diagnosis based on what? Based on their self-report. So in 2009, I don't know whether I'm clear, in September 2008, they did SCL 90. In 2009, they have again used SCL 90 on, and they found 66 students had IA criteria on Young's diagnostic questionnaire. So they are saying that within last 1 year, they have developed internet addiction. So what they did, out of this 66, these people, 66 students who had IA, 7 were excluded because they were familiar with internet. When they entered university to graduate, that all changes took place in first year. So they did not want to take those 7 candidates into the study because they were already using internet. Okay, so they just included only 59 students out of the 66 because they were unfamiliar with internet as freshmen in 2008. So what they are trying to say is, these 59 students out of 2000, this 2132 students developed internet addictions. No, all this analysis, data analysis they have done on this 59 sample. Okay. So what they did, I'm going to talk about 2 parameters. First is mental states before addiction. So means what they did is, they had looked at the SCL scores of these 59 internet addicted students, and they found that they were less than norm for SCL 90 dimensions before their addiction. So in 2008, their score of OC dimension was more than normal. So they're trying to say that these 59 internet addicts had high OC symptoms more than what is norm on SCL 90 in 2008. So their interpretation is that more OC behavior before addiction to internet means OC behavior is significantly related to internet addiction. And they are proposing that addiction is a brain disease that manifests as compulsive behavior, which is understandable because this is what is consistent with other studies also. Shapira, this is an old study, 2003, but this is a very good study because it says that internet addiction is highly correlated to or highly associated with internet addiction. This is a good observation. So what they are observing, what they have proposed is that there is a relation between obsessive compulsive behavior and internet addiction disorder. What they did when people became addicted to internet, what they found was that the scores of OC, depression, anxiety, and hostility in IIDs was much more than norm. So what they are saying that IA students suffered from these pathological problems. So depression and anxiety is associated with IED, which is again a welcome finding, because they are trying to say that all those individuals who have OC, depression, anxiety, and hostility are likely to develop internet addiction disorder. They also said that those who are having high hostility are more likely to develop internet addiction. And what they have said is it may be because of interpersonal conflict and rejection because of high hostility, and substances are less available to them. Internet provides opportunity to escape from the stress of real world. So this is a very, I think, interpretation, very loose interpretation. So just because they have found that high hostility was there in those who are addicted to internet, they are saying that probably they are not getting a chance to express their hostility. So they are finding internet as a mode to get addicted to. So this is something which is not digestible. Okay. So then what they did, they have found some highlight. They have talked about highlights from 2008 and 2009, SCL 90 scores. They found that interpersonal sensitivity, depression, anxiety, hostility, and psychotism scores changed significantly between 2008 and 2009. So this SCL 90 was administered at 2008 and 2009. And what they are saying is at 2009, all these scores changed significantly between 2008 to 2009. But somatization, OCD, phobic anxiety, paranoid ideation did not change. So they are saying these dimensions are not related to IAD. Now, this is something I cannot digest. They are saying that IAD induces harm, comorbidities, example, mood disorders, attention disorders, SUDs. So just because they found an association between internet addiction and comorbidity, they are saying that internet addiction is leading to this. So this is in extension to a previous student who asked. So I was talking about this causality. In cross-sectional studies, we cannot talk about causation. Only in longitudinal follow-up. For example, if you are seeing a population now and you are again following them up for say next 1 or 2 years, then if you are seeing any difference, then you can say that, okay, this is leading to that. But in a cross-sectional study, you cannot say. Fine, these people also have done a follow-up study between 2009. But what they are saying is that just because they found that there is no comorbidity at 2008 and they have developed 2009, they are saying that IAD is, they did not find IAD at 2008, but they found IAD at 2009. Similarly, they found comorbidity at 2009. So they are proposing that internet addiction disorder is actually leading to these disorders, mood disorders, attention disorders, and SUDs. So my comment is about the cause-effect relation, which started first. Is it that these people had comorbidities and it led to internet addiction disorder? Or is it that internet addiction disorder actually led to comorbidity? Okay. Now, another thing they are saying that in 2008, the OC score was much more than norm before ACD, which could be a predictor for IAD. In 2009, score did not change significantly. So OC is not related to IAD. So this is something confusing. In 2008, they found high levels of OC scores on SCL 90. In 2009 also, they found the same scores. Just because they found that the scores did not differ between 2008 2009, they are saying that OC is not related to IAD. Okay, my comment here is, unless you provide a treatment, how do you know? Okay, their second finding was depression, anxiety, and hostility. In 2008, it was less lower than norm. In 2009, like I was talking about, the scores were high. So they are saying that IAD has led to all these issues. So depression, anxiety, and hostility, they are saying are outcomes of IAD. Now, again, they are talking about interpersonal sensitivity and psychotism. They are saying that it was normal in 8, and in 2009, it changed significantly. So they are saying that interpersonal sensitivity and psychotic dimensions are highly related to IAD. Now, the conclusion of these authors is that there is no pathological predictor for internet addiction. IAD leads to pathological problems. So there are major methodological issues with this problem. More important than are the ethical issues. I'll just, for your information, I'll just post this link into the your chat box. You please go through this paper when you are at leisure. and you'll understand what crap it is. Sorry to say this, but I feel very angry when people talk about internet addiction. So that's my conflict of interest. But yeah. Yeah. So what they have done is they have said that they have followed the uh, Declaration of Helsinki Protocol, and then they have also followed the 1964 Declaration of Helsinki Protocol that had a EC approval. But unfortunately, what happened in September 2008, they have actually administered SCL 90. They did all the analysis, but they have not taken consent from these individuals. The rationale for these people not taking consent in 2008 is that their university policies requires that students' mental fitness on SCL 90 should be assessed when they enter university. In September 2009, they took consent. So this is a problem. Now, my another issue here is my another concern from the ethical aspect is that is what one of the students also pointed out. In 2008, they found that these people were scoring high on OC dimension and they did not give any treatment. So this is a major ethical issue. That so for the attention of students, we should always remember that the interest of society should take over the interest of science. Just because we want to do a wonderful study, we should not withhold treatment for people who actually need treatment. So this is a basic premise of doing research. So in 2008, when they found that these people had OC symptoms, they did not give any treatment and whatever methodological problems. So I find that this study is a very, very bad study, unfortunately published in a very good journal. So just because a study is published in a very good journal with a high impact factor does not mean it's a wonderful paper. Okay, now I will also talk about, there are a lot of crap available internationally. I will also talk about one particular paper from India. I deliberately did not mention the names of the authors. It actually talks about internet addiction disorder withdrawal psychosis. There are two case reports. They're saying that as soon as the people stop watching internet, they have developed psychotic symptoms. And I also remember reading a paper in 2017 where they say that people who are actually watching porn and are so-called addicted to porn addiction, the so-called cyber porn addiction, subtype of internet addiction, develop paranoia. And how they are defining paranoia, they have this suspicions that people are actually following them. They are watching their laptop, or the police will come and catch hold of them. So these are the papers. So like this, lot of papers are published internationally. Okay, now I will just talk about a very brief paper because this is what we did in, this was again an old paper. We published in 2015 in this in innovative clinical neurosciences. What we try to do is, I always thought that internet addiction is not a separate disorder. It is actually a manifestation of some underlying problem. And I have been always talking about this. What we did is, this was actually again a very, very small sample as like my previous paper. This was only, this was a treatment seeking population who came to our clinic. So we took pure OCD cases, 38 in number. By pure, we mean they did not have any comorbidities, no psychiatric comorbidities. And then there were controls around 34. So when we did YDQ, that is Young's Diagnostic Questionnaire, at baseline, 11 were found to be internet addicted and 3 out of these 34 controls were having internet addiction. So this was a statistically significant value, P is equal to 0.03. And what we did is this 38, we again divided into two groups, subgroups, OCD with internet addiction and OCD without internet addiction. This 38 were divided into two groups. We found that the internet addiction test scores was higher in those OCD who had internet addiction compared to those who did not have internet addiction. So p-value was again significant. What we did next was, We followed up these people. So this was we took a EC approval, we took a return informed consent for this population. We followed up these people for next 1 year, and we provided treatment as usual for those people who had OCD and general advice regarding internet addiction, whatever is available, we told we had given them. So what we found is these are the 4 time points. This is a baseline, this is at 3rd month, this is at 6th month, and this is at 1 year. These are the IIT scores. Okay, these are the various time periods. So this is the OCD group with internet addiction, this one, and this is OCD without internet addiction. So if you see, there was a significant positive correlation. This is a Pearson's correlation at baseline, 3rd month, 6 months, and 12 months. So as over a period of 1 year, their IIT scores fell down when we gave treatment compared to those OCD group who are not internet addicted. Okay, somewhere we know that internet addiction is actually having some impact on OCD, but what we are trying to tell through this picture is that OCD is the background culprit, which is putting people at risk for internet addiction, not anything else. So what we try to prove here is that treatment of OCD improved Y-box. So they, at baseline, compared to baseline, even at this 1 year, the Y-box score and IIT scores both fell down. And at the end of 1 year, only 2 patients with OCD continued to fulfill the YDQ criteria for internet addiction. Okay, so our conclusion with that meager sample, we just proposed that treatment of underlying disorder, that is OCD, improved IA. And I would humbly say that in 2015, ours was probably one of those very few papers which actually talked about the progression of internet addiction with treatment. And even at that time, the treatment modalities for internet addiction was SSRIs and some CBTs and all that. Okay, we did not give any CBT, but anyway, we give SSRIs for OCD patients. So all these OCD patients receive treatment. So what we are trying to say, whatever SSRI treatment we give for OCD, that actually helped improve even the internet addiction. Anyway, the controls did not receive any treatment. So this was a small paper, but this has been something which I felt where we did good. Okay. Now there are few genetic studies also. I will just talk about one genetic study, which is again a crap. What they did is they extracted DNA from the blood samples of IIDs and controls. Controls basically mean those who did not have any psychiatric illness. So this was the cases and this was the controls. Okay. So what they found is there were 72 SNPs in 24 genes, which were significantly associated with IID. And most of these SNPs were risk factors for psychiatric disorders. More similarity detected with ASD, BPD, and schizophrenia, and higher anxiety, stress, neuroticism, and deficits in working memory, attention planning. So what they are trying to find is that there is a genetic linkage in those people who have internet addiction disorder in those who also have psychiatric disorders. So the conclusion is they are saying that this is one of the first genome-wide association study, and IID has strong shared genetic basis with neurodevelopmental disabilities and psychiatric disorder. And they are saying that the genetic risk factors in IIDs cause cognitive and neurodevelopmental brain dysfunctional abnormalities, which lead to excessive internet use. And IID is a marker for vulnerability to developmental psychiatric disorder. So my comment here is, this is the cross-section study, and my comment here is whatever SNM and SNP changes they found could be because of these issues, because of neurodevelopmental disorders and psychiatric disorder. How can they say that it is because of IID? First. Second is, this is a cross-section study. Like I was earlier saying, in a cross-section study, we cannot talk about causation. Only when you follow up these people, you can find out. Okay. So this is another very prestigious journal, Research in Developmental Disabilities. This is, I think, from Springer. This is a recent paper published in 2023. Okay. Now, what I also did is I did a search on PubMed with keywords internet addiction disorder. I just looked for systematic reviews and meta-analysis. This I just did 2 days back. So there were few papers. This was a paper published in 2024. This is about only the cross-sectional study where they found that pooled prevalence of internet addiction is 24%. Mind you, there were no mental health professionals in this particular systematic review. So this is about the prevalence of internet addiction in medical student, in Asian college students. The prevalence is 24%. Now, this is another paper which was about the association of internet addiction and mental disorders. I was very much excited because this is what many of the people actually are saying, that if at all there is some concept called internet addiction disorder, it is because of the comorbid or underlying mental disorders. Fortunately, there's a psychiatrist in this group. So they found a small positive correlation of internet addiction disorder with sleep disorders, anxiety and depression and stress. So this particular paper, systematic review says that there is association between internet addiction with other psychiatric disorders. Okay. So now this is about the intervention, the treatments. Again, there is no mental health professional in this particular systematic review. What they are saying, they have actually done a systematic review on all those papers where they have used children's education, parenting strategy, physical activity and counseling, and they say that these are efficacious modalities as they are efficacious in reducing internet addiction in young children. This is another paper. This is a meta-analysis which is published in the Journal of Affective Disorder, very high-ranking journal. Unfortunately, again, there is no mental health professional here. Okay, and they said that focused solution short-term therapy is the best intervention for people with internet addiction disorder. So what are the controversies now? Many researchers have investigated the validity of these categories. Researchers favoring the listing in DSM, example, people like Block, say that IAD has enough criteria to be included at least in substance dependence family. They say don't put it as a separate disorder, but at least club it under substance dependence disorder. There was a lot of heated debates. There's one particular group which says no, it is a full-fledged standalone psychiatric disorder. It merits inclusion in DSM-5 as a separate disorder. There was another group which says evidence is limited. So it should not be. That is why pending further research, DSM-5 has actually put it under the rubric of, it did not include it as a major psychiatric disorder, but as an entity which needs further research. Okay. Now, again, I did a PubMed search with keywords internet addiction disorder. I found original articles 247, review articles 273, systematic reviews meta-analysis 153. Okay, now there's a lot of over-enthusiasm. I'm very sorry to say, sorry for using such bad words like crap and all that, but I feel very, very aggressive and enraged when people just use rating scales at a face of it. That's why, like, I think somebody, Nirmal sir, said that we published this book on rating scales. I request all of you to please read the first chapter, which is authored by me, Vikas Menon, and Dr. Sandeep Grover. Please read that paper, like what I have been always thinking through my PG days. I always say that rating scales needs proper training. And as postgraduates, as faculty, we should have enough training and expertise in using rating scales. Unfortunately, all these people, I don't know whether any of the audience has this, but I apologize for that. But if you see, I was talking, these original articles 247. If you go through each paper, these are the people who are the authors. SPM, physiology, pediatricians, psychologists still find there's nothing wrong. Statisticians, sports science, physical education. There's a paper where all the authors are these people. How can they talk about internet addiction is my question. And please understand that all this internet addiction research is coming from China and Korea. There's a reason for that. It is said there is a reason why there's so much of internet addiction from these countries. There are a lot of reasons. There are political reasons. And if you see, and India also is taking the lead in internet addiction research by all these people. Okay, reasons. West, if you see, surprisingly, there's not much research from West. So what is the reasons? One very important reason is promotions. All of us want promotions in our career from assistant to associate, associate to professor. And then what we do, very easy to do internet addiction research, use IIT, use YDQ, go to a class of 150 students, or just send a Google survey link on WhatsApp, get something, get some results, do statistical analysis, and just find some results. Okay, I think this is a very bad way. I was talking about scales. I have seen people even administering HAMD, YMRS, MADRS online. We should remember that these are the instruments which have to be administered face to face. We cannot use HAMD, MADRS, YMRS, and all these instruments online. But if you see, all these people administer these instruments online. I have seen so many papers. Okay, so there are a lot of reasons for this internet addiction research from this country. Please have a look at PubMed, see how many papers are coming from these two countries. So there was one very good paper by these two authors in 2016. Actually, this was a rebuttal to my letter to editor. So this particular group from PGI Chandigarh had published a editorial in IJP. Following that, I gave a letter to editor, and then they gave me back. They were very, very angry at me. But my intention was not to hurt them. But I'll just talk about this particular paper. What they have said is, this is the main controversy. Dalal Basu and Basu from PGI Chandigarh say that these are the four major controversies in IA research. Is IA a disorder or a continuum of normal behavior? Is this type of behavior indicative of any addictive behavior? How can someone get addicted to something that is not as noticeable as drugs? See, for example, in people with alcohol use disorders, we clearly know there is alcohol and this is what they are getting addicted to net. So addicted to. In internet addiction, what are they getting addicted to? Is it to mouse? Is it to laptop? Is it to communication media? Is it to the type? Is it to shopping? Is it to porn? What are they getting addicted to? Why isn't it more accurately described as symptom of underlying psychiatry? This is something where I feel very, very important. I feel that it is very important that we should look for underlying psychiatric disorder. And why isn't it more accurately defined as impulse control disorder or obsessive compulsive spectrum disorder? Because there is a lot of research to say that people with impulse control disorder and obsessive compulsive spectrum disorders are highly likely to develop internet addiction. What is the person addicted to if this is an addictive disorder? If we consider IUD to be a single, all-encompassing term with several subtypes, according to certain internet apps, how to diagnose such an illness? Even diagnostic criteria is not very clear. So this is a major criticism about internet addiction. Okay, now what are my views about internet addiction? I was talking about this very easy approach. Go to a college, administer YDQ, get a score, and though all those people who are having more than cutoff are internet addicted. My very, very important concern is this, that we are not doing a thorough MSc, we are not taking a proper history, we are not doing a proper MSc. More so, there should be a qualified mental health professional, a psychiatrist or a psychologist, or max, there should be a psychiatric nurse or a psychosocial worker who should be assessing these individuals for underlying or comorbid psychiatric conditions. Unless we do that, we cannot diagnose a person as internet addiction. My recommendation is there is a very strong need for methodologically rigorous approach. There is a need for extensive direct face-to-face interview. We cannot do it online. There is a need for appropriate IA diagnostic instrument. There is a need to address psychiatric comorbidity. And those who actually, in fact, if there are any IA patients, there is a need for evidence-based treatment of underlying comorbid condition. And there is a need to follow up these people to see whether with treatment is this so-called IID still persisting. In summary, if you see technological addictions, I really get bugged up with this. Social media, Facebook addiction, Instagram addiction, smartphone addiction, selfie addiction. Now, a recent concept is FOMO, fear of missing out. There are so many papers coming on that. All these work-related digital addictions. So what I feel is internet addiction is a Me Too diagnosis. There's a need for good evidence-based skills, there's a need for good evidence-based treatment. So I still believe internet addiction is a hypermyth. So this is a letter to editor which I had published in IJP, in response to which Dr. Dalal and Basu gave a strong rebuttal. I said, internet addiction to a maximum extent is a manifestation of underlying or comorbid psychopathology. Internet addiction is hype, it is a myth. It does not merit inclusion as a standalone psychiatric disorder. Unfortunately, my paper was never cited. The only citation it has got is from Dr. Dalal and Basu. Okay, and there are so many papers which are published from India, but nobody, I'm not saying that it needs to be cited, but what I'm trying to say is, I feel that it's a good small piece of work, but unfortunately, the internet addiction literature still comes up. So I have stopped publishing on that. But when Shivaraman sir had actually asked me to talk about something today, I thought that this is some topic which I should definitely take up because I very strongly feel about it. Even at Indian Journal of Psychological Medicine, we are very, very particular that we are not going to publish articles related to all these so-called technological addictions. Also, COVID-related papers we are not publishing because they are not needed anymore. They are not novel. Unless and until, like the one which was published from submitted from NIMANS, it was a very good article because it was a systematic review and meta-analysis on the evidence which is there in India. So we felt that it was worth publishing and it is available online. So this is a very, very important, this is how I got to do this. My small piece of work. Peace in 2009 said, should DSM-5 designate internet addiction a mental disorder? He said, the so-called internet addiction should not be written off as another attempt by psychiatry to medicalize unfortunate or self-destructive behaviors. I feel that it is unnecessary. We are unnecessarily medicalizing a behavior which is normal to human population. So as an editor, I had told what I do in treatment. No, one bigger problem is all of us, especially as mental health professionals, pediatricians, we keep on telling everywhere that internet addiction, we keep on talking about it. Now it has gone into the parents' mind. So what happens? They come with the child, they say, sir, my son is addicted to internet. Sir, my daughter is using net whole night. I say, are you not watching internet? Are you not watching TV and YouTube? So just because your child is watching internet or using YouTube or using Facebook for a long time, I don't think that we should really address that issue. There's a need for a lot of reassurance. And if at all, in our assessment, clinical assessment, we feel that, okay, definitely this is a major issue of concern. We should first look for comorbidity. And I'm telling, please look into the comorbidity. Many of them have underlying social anxiety disorders, OCDs, impulse control disorders, and all of the depression. This is comorbidity is a very important concern in these people. So my disclaimer, this is solely based on the literature which is available. So that also I had just cherry picked and largely based on my personal opinion. So I request all the students and faculty to have a critical and open view, and please keep on publishing if you feel it is worth. Thank you so much.
A very good evening to everyone. On behalf of Indian Psychiatric Society, Tamil Nadu chapter, the Research Capacity Building Committee, I take this opportunity to extend our sincere thanks to all those who made the session successful. First and foremost, I express my heartfelt gratitude to our distinguished speaker, Dr. Rajshekhar sir, for his enlightening presentation on internet addiction. Your insights have greatly contributed to our understanding of this important topic, and we are truly thankful for your time and expertise. I would like to thank Dr. Prajot Singh Dillon for an engaging journal presentation, and our moderators, Dr. Shivanand sir and Dr. Anbalagan sir, for smoothly guiding today's proceedings. And special thanks to Dr. Shivaraman sir for setting up the meeting, and Dr. Nirmal sir for warm welcome and introduction. I would like to extend my gratitude to all our resource persons, participants, and attendees who joined us today. Your presence and active involvement are what makes sessions like this so valuable. I also want to acknowledge the efforts of the entire RCBCT and the IPS Tamil Nadu chapter office bearers for organizing this event and ensuring its smooth execution. Your dedication is much appreciated. And finally, a special thank to East West Pharma for their support in making this event possible. Thank you all once again, and I look forward to many more such productive sessions in future. Thank you.